everyone. Welcome to the discussion of inflammatory bowel disease. Inflammatory bowel disease is broadly categorized into three types. The first category is Crohn's disease. Crohn's disease is also known as alternative names like regional ileitis because it tends to involve the ileal region, the small intestine more commonly. It is also called as regional enteritis, that is, it is a regional disease, regional localized inflammation. Second is your ulcerative colitis. As the name itself is saying, there is inflammation of the colon. So it mainly involves the rectosigmoid and colonic region, and there are ulcers which are the hallmark of the disease. And the third variety is indeterminate colitis. Many types of IBDs, you cannot find whether it is falling into the spectrum of Crohn's disease or it is falling into ulcerative colitis, and so they are called as indeterminate colitis. Indeterminate colitis, according to Nelson, it constitutes about 10% of all IBDs in case of children. Now, which is more common than among Crohn's disease and ulcerative colitis? There is no clear answer to this. It varies across the populations, it varies across the age groups, and in general, we don't try to take sides because this is one complex area that which is more common. It varies from individual to individual, and the prevalence, as we shall see, depends upon various factors which cannot be categorized simply into one or the other. So that is why we simply say inflammatory bowel disease is of three types, with colitis being 10%, the remaining 90% being either Crohn's disease or ulcerative colitis. Moving further, what is the etiopathogenesis? Now, etiopathogenesis of inflammatory bowel disease is a complex one. It's a complex interplay of a genetic predisposition, precipitating factors, many of them which are environmental. There is a role of positive family history, and there is immune dysregulation. As we shall see, there are some GI infections which can precipitate IBD, particularly Crohn's disease. Also, mucosal barrier in the intestine, when it is disrupted, as you may find in altered gut microbiota or with injudicious use of antibiotics, they can cause entry of various antigens into the system, eliciting a strong inflammatory reaction. So it is a complex multifactorial interplay of etiopathogenesis. The first thing that we need to discuss are the genetic factors which are implicated, which increase the risk of developing IBD. First is higher concordance rates have been found in monozygotic twins compared to dizygotic twins. Nelson says that concordance rate in monozygotic twins is 36% in case of Crohn's disease and 16% in case of ulcerative colitis. So if somebody asks you which disease out of these two will have a higher risk of developing in monozygotic twin, the answer will be Crohn's disease. Second is positive family history. The risk varies between 7 to 30% in the children according to Nelson, whereas Harrison gives a range of about 10% in case of adults. So if you see, 10% also lies within the same range only. So in children, positive family history association is 7 to 30%. In case of adults, according to Harrison 20th edition, it is 10%. A child who has both parents having IBD, the risk is more than 35%. Harrison gives a value of 36%. So they are almost identical. So if a child is having both parents having either ulcerative colitis or Crohn's disease, the child will be having a risk of more than 35%. You need to understand that positive family history of IBD means if a patient is having ulcerative colitis in the family, that does not mean that he will only develop ulcerative colitis, he can also develop Crohn's disease as well. More and more we are understanding that these two types of IBDs, they tend to have an overlap of the spectrum. Of course, they are distinct diseases and distinct predisposition factors have been proposed for them. Crohn's disease shows a greater association with positive family history than ulcerative colitis. So twin also, family history also, Crohn's disease will be more common than ulcerative colitis. Then there is an association associated with genetic syndromes. Already super specialty MCQ on this has been asked. So what I have done is I have clubbed all the genetic syndromes described. I have taken the help of Nelson, Robbins 10th edition and Harrison 20th edition. So this list is an amalgamation of all three, Nelson, Harrison and Robbins. So Turner syndrome is a frequent association of these inflammatory bowel disease. Secondly, Hermansky-Pudlak syndrome. If you remember, we have already talked about this in a separate module. Hermansky-Pudlak syndrome patients will have albinism, they will have bleeding disorders, and they will have increased risk of developing ulcerative colitis and Crohn's disease. Then GSD type 1b. Glycogen storage disease type 1 is the usual von Girk disease. There is a variant of it called as 1b in which the translocase, the transporting enzyme, is deficient, and this is the variety which is associated with high risk of IBD. Rarely this IBDs may be associated with Wiskott-Aldrich syndrome, IPEX syndrome, and ankylosing spondylitis. Ankylosing spondylitis association is strongly seen with patients of ulcerative colitis than Crohn's disease. Now, hot thing, what are the recently identified genes which are associated with IBD? There are huge tables given in all the pediatric GI textbooks as well as in Nelson and Harrison. But what I have done is I have picked up the important things and simplified the table for your understanding. So, on one side we will have the gene, then in the middle we will have the name of the gene, what function that gene is performing, and which IBD is associated with it. Most of the genetic loci have been found to be associated with Crohn's disease as compared to ulcerative colitis. So let us look at the table. So this is the table you are supposed to remember. It's a handmade table I have made. So NOD2 gene. NOD2 was the first gene to be identified associated with IBD in the year 2001. NOD2 means it codes for a protein called as nucleotide binding oligomerization domain containing protein type 2. This is a protein which is involved in innate immune responses and it is associated with high risk of Crohn's disease. IL-10 codes for interleukin 10. It is involved in immune tolerance. It again is associated with Crohn's disease. We have interleukin 10 RA and RB. These code for the two types of receptors for interleukin 10. They are also a part of immune tolerance. I hope you know that interleukin 10 is a relative anti-inflammatory cytokine. And any genetic mutation in this gene will lead to pro-inflammatory state producing Crohn's disease. Then we have interleukin 23R, which codes for receptor of interleukin 23. It is a part of the helper T17 pathway and again it increases the risk of Crohn's disease. We have TKY2, which codes for tyrosine kinase protein type 2. It is again a part of Th17 pathway and it increases the risk of both Crohn's and ulcerative colitis. So this is one thing which is different. So TKY2 will increase the risk of both Crohn's and ulcerative colitis. Then we have IRGM, which codes for immunity related GTPase M protein. It has a role in autophagy and it increases the risk of Crohn's disease. Then we have ATG16L1, which codes for autophagy related 16 like 1 protein. It has a role in autophagy and increases the risk of Crohn's disease. These tables will be given to you obviously as a part of your notes and the video is already there with you. End of the day you have to cram them up. So understanding is one part, but no entrance exam can be qualified without you mugging up a few things. So this is one table that you must mug up. It is a hot thing. It is a new, you can say a thing which is trending these days when it comes to the discussion and the review articles of all these Crohn's disease and ulcerative colitis. Continuing further, these are the remaining ones. SLC22A4 is the gene which codes for a solute carrier protein and it is a solute transporter associated with Crohn's disease. If mutations occur here, it leads to Crohn's disease in the patient. Then we have CCL2, which codes for C-CIF motif ligand, chemokine ligand type 2. It is involved in chemotaxis of monocytes and again it increases the risk of Crohn's disease. Then we have CARD9, which is a caspase recruitment domain family member 9 involved in apoptosis regulation and oxidative stress regulation. This is involved in both Crohn's disease and ulcerative colitis. So this is the second gene that you must remember, both Crohn and ulcerative. Third is interleukin 2, which is involved in only ulcerative colitis. So this is a different one, can be asked in exam. It is a T cell regulator. And then we have MUC19, which codes for mucin 19. It is a critical protein involved in epithelial barrier formation and can cause both ulcerative colitis and Crohn's disease. So in general, the name of the genes you should remember. Which gene is associated with Crohn's disease? Easy way to remember is remember the name and only identify which are the ones which are associated with both Crohn's and ulcerative and only with ulcerative. The remaining ones will all be associated with Crohn's disease. Moving further, the second group of features after genetic features are the environmental factors. A lot of environmental factors have been implicated in the pathogenesis of IBD. First is the role of gut microbiota. When humans are born, their gut is sterile. But as we start consuming food, even in the neonatal period, colonization of gut begins. There are a lot of bacteria which are beneficial, and there are a lot of bacteria which may have a potential pathogenic role. There is a delicate balance which exists. Studies have shown that gut microbiota is critical in maintaining the gut epithelial barrier function. Whenever there will be alteration of the gut flora, when will alteration of gut flora happen? When extensive antibiotic use happens or some GI illness happens, you will have alteration of gut microbiota, which will result in probably alteration in the epithelial barrier. All the antigens will be able to enter into the mucosal cells. There will be inflammation starting. This inflammation can start the cascade for inflammatory bowel disease. So role of gut microbiota is a hot active thing. Studies have shown that patients who have gut microbiota dysfunctionality, if you give them probiotics, there may be a role of improvement in the risk of developing IBD. The IBD risk may be minimized in those with genetic factors. How much the role exactly is, we do not know. It is still an area of active research. Second environmental factor, as I said, antibiotic use in the first year of life. Harrison says if the child has received multiple antibiotics in the first year of life, there is a 2.9 times higher risk of developing inflammatory bowel disease. This is a very important point. Third thing, breastfeeding has a protective role. Recent studies, two studies have shown that vitamin D may also have a protective role in Crohn's disease. Crohn's disease shows a higher prevalence in higher socioeconomic status as well as use of OCPs in women. Now you need to understand that IBD is a disease which is more common in Western countries, in the developed nations. But all textbooks agree that countries which are becoming rapidly westernized, rapidly industrialized, more affluent, which includes India. They have given the example of South Korea, India, China, they have given the example of Japan. These are Brazil. They have said these countries traditionally had low incidence of IBD, but as they are becoming more affluent, the IBD risk in them is rising, including in case of children. And that shows that there is some environmental role, some socioeconomic status role in the pathogenesis of this disease. Smoking is interesting here. Smoking causes Crohn's disease but is protective against ulcerative colitis. Western diet with more refined sugars and less fresh fruits and vegetables is the one which predisposes. So all these, burgers, pizzas, mayonnaise, all these processed foods, tinned foods, reheating foods, ready-made teas and coffees which are there, more extensive use of it instead of using organic and fresher foods, that is associated with the risk of developing IBD. Two of the textbooks, not Nelson, but other two textbooks, they say that a diet which is high in saturated fatty acids, trans fats, and diet which is rich in omega-6 fatty acids increases the role of developing IBD, whereas omega-3 fatty acids, particularly those found in fish oils, they have been shown to decrease the risk of developing IBD. Then appendectomy, if it is done, obviously we will not do prophylactically, but appendectomy, if it is done, removal of appendix done for acute appendicitis at an early age has a protective effect on ulcerative colitis. Then infectious gastroenteritis with pathogens like Salmonella, Shigella, Campylobacter and Clostridium difficile increases the IBD risk by 2 to 3-fold. So these are the environmental factors which have been implicated in development of IBD. Third, we move to immune factors. P-ANCA, that is perinuclear anti-neutrophil cytoplasmic antibody, is positive in 70% of ulcerative colitis and less than 20% patients of Crohn's disease. On the other hand, ASCA, that is anti-Saccharomyces cerevisiae antibody, is positive in 55% patients of Crohn's disease and it is considered to be a surrogate marker for Crohn's disease. Higher interleukin-1 production in all forms of IBD has been shown. So this is the typical, immune dysfunction which is happening, and this is producing IBD in the patient. So as you can see, there is a role of microbial flora here. All these genes increase the risk of genetic susceptibility. There is a role of immune dysregulation and there is a role of environmental factors. They all interchange, they all combine, they all promote and have a synergistic role in developing inflammatory bowel disease, affecting the immune function of the epithelial cells, producing inflammation in them. So there is an immune orchestra which operates in IBD. What is an orchestra? You have seen all orchestras. So, there will be a lot of people will be sitting together. They will have their own instruments. One person will start playing the instrument, then others will join in, then that person will go away, then a synchrony will build up and the music will be produced. If an orchestra is good, the music produced is pleasant to your ears, pleasant to the soul. But the orchestra we are talking about here is life-threatening potentially, that is immune orchestra and IBD. Immune orchestra means a few specific pathways are activated which have a synergistic role and which result in development of IBD. You need to understand that in IBD, it is found that T cell mediated inflammation has been proposed to be a major role compared to B cell mediated inflammation. Although antibodies have been found to be associated, but it is primarily a T cell mediated inflammation. There are three pathways which have been found to be implicated and which produce the immune orchestra. The first pathway is Th1 pathway, also called as helper T cell 1 pathway. This pathway is associated with increased production of interleukin 1 as well as tumor necrosis factor alpha and interferon gamma. We have the second pathway, Th2 pathway, which is associated with production of interleukin 4, interleukin 2, interleukin 5 and interleukin 13. And third is your Th17 pathway, which is involved with production of interleukin 17, interleukin 21 and interleukin 23. These are the three pathways which have a synergistic role in producing the features of inflammatory bowel disease. However, it is not so simple. It is found that Th17 also has a protective role. So, a dual type of role is seen, and this is where the role of microbiomes and environmental factors come into play. And it is found that interleukin 12, which is induced by various pathogens, interleukin 1 which is produced by the activated macrophages. This is the one which is responsible for activating the Th1 pathway, and this in turn can influence the development of both Th2 and Th17 pathways. This is produced in response to infection by the various gut associated infections. So this is the overall immune orchestra which operates. Specific new biological agents are being developed which target specific areas of this immune orchestra. Whatever I have mentioned here is the bare minimum key points. The actual pathogenesis is a lot more complex. Fortunately, for super specialty exam, we need not go into more fine details than this. Now, what is the age and gender distribution that we find in IBD? Approximately 25% of all IBD patients, according to Nelson, they present before 20 years of age. So, the role of pediatricians is important in IBD. It shows a bimodal distribution. A large peak is seen between the age group of 10 to 20 years. So, most of the patients of IBD will present in 10 to 20 years. There is a relatively smaller peak where cases will occur between 50 to 80 years of age. But this is the peak which is being increasingly identified, and more questions now are being asked on IBD in pediatric exams. Children with early onset IBD are more likely to have colonic involvement. And in case of ulcerative colitis, males are more commonly affected than females slightly, whereas in Crohn's disease, the ratio becomes slightly different. Females are slightly more commonly affected as compared to males. Now let us discuss the comparative features of IBD. We'll be doing it. See, IBD is a huge topic, and end of the day, you don't want to do a thesis on that, and I don't want to create a 4 or 5 hour video on IBD and create a problem for you how to revise it. So what I've done is, we have talked about the etiopathogenesis now, key features. Now I'll be doing the comparative features of IBD related to pathology, clinical features, etc. and the extraintestinal manifestations. So these will be tabulated forms. After that, in the end, I will be talking about each disease separately, the points which have not been discussed, and we will discuss the management of each. So it will save your time but will be more productive, easy for you to revise. So let us discuss the comparative features of IBD. First, I'll talk about pathology in IBD, and the reference we'll be using here is based upon Nelson as well as Robbins' 10th edition. So pathology wise, as you can see, when you look at macroscopically, that is grossly, Crohn's disease tends to develop, the most commonly involved area is ileum, That is why we call it as regional ileitis. Colonic involvement may or may not happen, right? In fact, Harrison also says that theoretically, Crohn's disease can involve any part from mouth to anus. But more commonly, ileum is characteristically involved, colon is sometimes involved. Ulcerative colitis, the name is, naam mein likha hai, colon ka inflammation, so it will not happen anywhere else, it involves colon only. However, about 5 to 10% patients can have backwash ileitis. Backwash ileitis is a term which means that in case there is extensive full colon involvement, sometimes few features of inflammation can spill over into the terminal part of ileum. That we say backwash ho gaya inflammation ka. So we call it as backwash ileitis. Then distribution. Crohn's disease is not diffuse. There are always skip lesions which are happening. So in Crohn's disease, there will be an intensely inflamed part, then some normal gut. Then intensely inflamed part, then some normal gut. Whereas colitis will have a diffuse involvement. Diffuse means there will be, if this is the colon involvement in Crohn's disease and this is the involvement in ulcerative colitis, the involvement will be in Crohn's disease like this, right? Whereas in ulcerative colitis, it will be like this, whatever part is involved. It will be a continuous distribution. There will be no skip areas happening. So this is how the distribution happens. Then is stricture formation. Stricture formation is a feature of Crohn's disease. They do not happen in ulcerative colitis. Wall appearance in Crohn's disease, the wall is thickened, whereas ulcerative colitis, the wall thickness is found to be normal. Now moving towards microscopy, we find that Crohn's disease is a transmural inflammation. That is, entire thickness of the gut is inflamed, and that is why stricture and fistula will form. In ulcerative colitis, only mucosal involvement is seen. Ulcer ban raha hai. It is not, the ulcer is not deep, it is not passing through and through. Only superficial mucosal ulcers will be present. Pseudopolyp formation is more marked in ulcerative colitis, although they can occur in Crohn's disease also. Then ulcers. Crohn's disease, deep knife-like ulcers, whereas ulcerative colitis, they are superficial, broad-based ulcers. Lymphoid reaction will be marked in Crohn's disease and moderate in ulcerative colitis. Fibrosis will be marked in Crohn's disease and they will not happen in ulcerative colitis. Serositis, serosa inflammation, wo tabhi hoga when there will be transmural inflammation. It will be more common in Crohn's disease compared to ulcerative colitis. Granuloma formation is more common in Crohn's disease. They occur in 35% patients. They are non-caseating granulomas. Whereas ulcerative colitis, no granuloma formation is there. Fistula and sinus formation will be seen in Crohn's disease, not seen in ulcerative colitis. So these are the major pathological features, distribution features that you need to remember. Next we move to the comparative features of clinical features in IBD. So there is a table I have made consulting 4 different books, easy for you to remember. On one side, again Crohn's disease, then we have ulcerative colitis. Bleeding per rectum in Crohn's disease can sometimes be seen, whereas ulcerative colitis commonly seen. Diarrhea with mucus and pus is common in ulcerative colitis, sometimes seen in Crohn's disease. Pain and systemic features will be more common in Crohn's disease. Abdominal pain, failure to thrive are common in Crohn's disease, sometimes in ulcerative colitis. Remember, abdominal mass will occur in Crohn's disease. It is never seen, no abdominal mass is seen in ulcerative colitis. Then perianal disease is common in Crohn's disease and it is rare in colitis. Stricture, fissure, fistula formation common in Crohn's disease, rare in ulcerative colitis. Colorectal disease involvement. Now, colon, you know that ileum is always involved in Crohn's disease, right? Colon can sometimes be involved. According to Nelson, colon is involved in 50 to 75% cases. Occasionally, rectal involvement can happen. And if there is colonic involvement, it is segmental because skip areas are there and asymmetric. Whereas in ulcerative colitis, colon and rectum are involved in almost 100% of these patients. And it will be a continuous involvement. Ileal involvement is common here. It is rare with backwash ileitis being present in some individuals. Next we come to the extra-intestinal involvement in IBD. What are the extra-intestinal features which are more common in Crohn's disease? MCQ in super speciality has been asked on this. So I've dedicated entire slide to this. So more common in Crohn's disease are oral aphthous ulcers. Second, peripheral arthritis is more common in Crohn's disease. Third, erythema nodosum, which is a skin lesion, is more common in Crohn's disease. Digital clubbing is more common in Crohn's disease. Episcleritis of the eyes is more common in CD. Renal stones and gallstones are more common in Crohn's disease. The type of renal stones seen are uric acid and oxalate stones. So gallstones also are more common in Crohn's disease. Moving towards ulcerative colitis, the things which are more common in ulcerative colitis include pyoderma gangrenosum. Old MCQ on this has been asked. There's sclerosing cholangitis, chronic active hepatitis, and ankylosing spondylitis are more common in ulcerative colitis. If somebody asks you overall, remember that extraintestinal manifestations are overall more common in Crohn's disease as compared to ulcerative colitis. The overall incidence is more common here. Now let us move our attention towards the individual details, and the first disease we'll be discussing is Crohn's disease. Crohn's disease is also known as regional ileitis. It is also called as regional enteritis, and because there is granuloma formation and it involves colon also, so one name, older name is granulomatous colitis as well. The key pathological feature of Crohn's disease we have already discussed, that ileum is commonly involved. There is transmural inflammation, that is the entire segment, entire thickness of the gut is involved, and skip areas are present. It is a discontinuous inflammation. So what are the peculiar features in pediatric Crohn's disease compared to adult? First of all, there is more extensive anatomical involvement seen in children than adults. Second is, at initial presentation, more than 50% are found to have ileocolitis. 30% are found to have upper GI involvement, which is very atypical in adults, and 20% have exclusive colonic involvement. Isolated small bowel disease, that is pure ileitis, which is commonly seen in adult, it is rare in children. And overall, isolated colonic involvement is more common in children as compared to adults. In case of adults, only colonic involvement is not common, whereas in children less than 8 years, you commonly find that the patient will be having Crohn's disease, but 20%, every 1 out of 5 children will have only colonic involvement being there. So it will be common in less than 8 years of age, and you will find that where there is purely colonic involvement, they will have features overlapping with those of ulcerative colitis, right? So the features of pediatric Crohn's disease are slightly different from what you find in adults, and all of these are potential statement based MCQ points for your entrance exam. Moving further, what are the clinical features of Crohn's disease? Now, broadly, 3 types of intestinal features have been described in Crohn's disease. The entire group of features can be divided into intestinal feature, non-intestinal, extra-intestinal feature, and systemic features, which will include your fever, weight loss, fatigability, etc. So, when we talk about intestinal features, there are 3 categories that are defined in Crohn's disease. The first category is inflammatory type. These are the patients who will have abdominal pain, because they are frequently having colonic involvement also, so they will have features of diarrhea, they will have features related to inflammation, etc. Second type of intestinal features will be related to stenosing type. So stenosing types are the ones in which colicky abdominal pain will be there. These are the children who will have features of malabsorption also, and these children will also develop features similar to intestinal obstruction. And third variety is the penetrating type. These are the children who will develop various types of fistulas, and there will be symptoms related to fistulas. You need to understand that these features are not exclusive, and they tend to overlap with one another. They may start as inflammatory, go on to stenosing type, some of the inflammatory one directly go on to penetrating type and develop features of fistula, and so on. Then the systemic features are found to be more common in Crohn's disease compared to ulcerative colitis. They include fever, malaise, and easy fatigability. Other than that, growth failure, delayed puberty, and amenorrhea is also found to be frequently common. Now, the classic triad of Crohn's disease which was proposed is diarrhea, weight loss, and abdominal pain, potential MCQ. However, we know that only 25% of children have the triad at presentation, and so this triad is becoming less popular. It is not very frequently referred to. Now, what does Nelson say? Nelson says that a stricture should be suspected in Crohn's disease if the child notes relief of symptoms along with sudden sensation of gurgling of intestinal contents through a localized region of the abdomen. So the older child will, or sometimes adolescent will typically give the history that, I am having abdominal pain localized here and there is fullness. And then there is a gurgling sound, audible sound which I can hear, and then there is a relief of the symptoms. So this will indicate that probably there is a stenosis in that area. Inflammatory obstruction versus fibrosis. They can be distinguished by either PET scan or MRI. The third thing is extraintestinal manifestations in Crohn's disease are more common in those cases where colonic involvement is seen, right? And finally, complications like short bowel syndrome, B12 and fat malabsorption are common in Crohn's disease compared to ulcerative colitis. The reason is very clear. Malabsorptive features are more common because it is involving the ileal region. Ileum is the part where all this absorption is going to happen. And ulcerative colitis, they will present more with diarrhea-like features, whereas these patients of Crohn's disease tend to present more with features of malabsorption, often associated with diarrhea. Now, what are the types of fistulas which are seen in Crohn's disease? These are the 6 types of fistulas which have been described. The first is enteroenteric type of fistula. Enteroenteric ones, they are commonly asymptomatic, or they may produce features of either malabsorption or bacterial overgrowth. Next is your enterocolonic fistulas which have been described. Third variety is enterovesical fistulas. Enterovesical means there will be a fistula between intestine on one side and there will be involvement of urinary bladder on the other. Enterovesical fistulas are commonly seen either in the ileal region or in the sigmoid flexure region of the colon along with the bladder. And these are the children who will have features like fecal uria. So fecal material will start getting passed into urine. They will also have recurrent increased incidence of UTI in these children. Then we have enterovaginal fistula, which is seen in some females. Enterovaginal is difficult to manage. Enterovaginal fistula, there will be a fistula between rectum on one side and vagina on the other side. So rectal vaginal fistula is the one that is called as enterovaginal fistula. These females will have a foul smelling or fecal smelling vaginal discharge. They are considered to be a nightmare to manage surgically. Then is enterocutaneous fistula. More commonly, enterocutaneous fistulas occur post-operatively as a complication of anastomotic leaks. And then we have perianal fistulas, which are found to be very common in Crohn's disease, and their management is entirely a different gamut of steps that you take. Now, what are the abscesses that you find in Crohn's disease? 4 types of abscesses have been described. There is a hepatic abscess, there is splenic abscess, there is anorectal abscess, which is a very painful abscess, and there is psoas abscess. Psoas abscess is often missed. It should be suspected when there is limitation of extension of the hip joint along with pain in the pelvic region, which may be irradiating even to the hip joint. So these are the patients in which psoas abscess should be suspected. How will you make the diagnosis of Crohn's disease in children? First of all, it is initially a non-specific presentation that you find, and almost 88% of prepubertal children have reduced height velocity. In fact, Nelson says that retardation of height and weight usually appears 1 to 2 years before the onset of intestinal features. And so a child who's having a short stature and non-specific abdominal complaints, one of the distinct possibilities that you should consider, particularly if there is a history of inflammatory bowel disease, you should think of inflammatory bowel disease. That is why a positive family history is so important. Taking a accurate history gives you a clue there. Then clinical features will help you in making the diagnosis along with perianal fistulas. Perianal fistulas are a very specific thing. There will be associated skin tags, and the perianal fistulas will have a purulent discharge. Normally we say that anorectal abscess is very painful, whereas perianal fistulas are usually painless. They may have a purulent discharge, but subjective features of pain are minimal in them. Then you can do blood investigations, or when you do blood investigations, you will find features of anemia in them. You will find raised TLC, ESR and CRP. but they are non-specific. Some of these patients may have serum albumin which is on the lower side, but they are all non-specific. Then we come to fecal markers of inflammation. We find that there are two fecal markers of inflammation which are elevated. There is increase in the fecal lactoferrin levels and there is increase in the fecal calprotectin levels. Especially calprotectin is a potential MCQ. It is a very sensitive marker. It is a very sensitive marker, high sensitivity and also good specificity for inflammatory bowel disease in childhood patients. Then GIT endoscopy can be done. GI endoscopy will give you the pathological picture that we discussed when we were discussing the differences between Crohn's disease versus ulcerative colitis. Now, upper GI contrast studies using barium can also be done. Barium is meal follow through is often done in these patients. There are two signs that are found. First is a narrowing can produce string sign in these patients, and second, multiple ulcers can produce a cobblestone appearance in these individuals. So have a look at this picture. Can you see that these are the black colored arrows which are showing the cobblestone appearance? I'm making them white. So what is cobblestone appearance? Barium will go down into the ulcers forming their outline like this. So that kind of outline is called as cobblestone appearance. Compare this appearance with this. This is the pavement which is showing a cobblestone appearance. So similar appearance if you find on barium, that is one of the clues for underlying Crohn's disease. Then when you do CT scan, there are two signs that you may find on CT scan of abdomen. First will be the sign called as comb sign. What is a comb? Comb is the one which you use to, comb your hair. So how does a comb look like? There is a comb has a handle like this, and then a comb has serrations like this. So if you do CT scan, you will find that there will be extra prominence of the vessels of the mesentery in the affected inflamed part. So there will be a segment, there will be a dilated segment where there will be inflammation in the gut, as you can see here, plus there will be small vessels which will be prominent across the mesentery. This will give an appearance as if a comb is there. We call it as a comb sign, which is seen in patients of Crohn's disease. Second sign is called as target sign, also called as halo sign. Target or halo sign will be produced in patients where there are deep-seated ulcers present in Crohn's disease. As you can see in this picture, multiple target or halo signs are being seen. The important thing is both comb sign as well as target halo sign, first of all, they are seen on CT scan better. Secondly, they are never diffuse. There may be multiple combs which may be visible because there are skip areas. Similarly, target sign, instead of a single target sign, you may find multiple target signs being present with apparent normal space in between, which will indicate that skip lesions are present, which again will be in favor of Crohn's disease of the patient. Other than that, other investigations like MRI can be done, PET scan can be done, and video capsule endoscopy can be done. But video capsule endoscopy will be contraindicated in case of stenosing or stricturing disease, because what will happen is the video capsule, the endoscope that you are putting in, that will get stuck up there. Now, how you are going to manage these patients? First is medical therapy. Usually there are two approaches used in Crohn's disease. First approach is step-up approach, which is more commonly used in children compared to adults. In step-up approaches, we initially start with a mild agent like 5-aminosalicylic acid with or without corticosteroid. Then if there is no response, we go into steroid sparing agent. If there is no response, we go in for stronger agents like biological agents. This is the step-up approach, right? The second is the step-down or top-down approach, which is more commonly used in adults compared to children. Having said that, there are certain pediatric gastroenterologists who are more comfortable with top-down approach even in children. No one approach is better over the other. When we say these, child more than adult, adult more than children, this is related to the general usage of these approaches. Top-down approach will be, you start with the strongest agent possible, like infliximab, induce remission, then you come down to 5-ASA. For intermittent remissions, you give steroids SOS. That is called as top-down approach. So what are the drugs that are being used? First of all, we have 5-aminosalicylates, also written as 5-ASA. These 5-ASA agents, they are useful in mild patients of Crohn's disease. Mesalamine is frequently used. There is also the prototype agent is sulfasalazine. But sulfasalazine is not very popular. It has more side effects. It is not well tolerated. So these days it is going out of fashion. But if question says sulfasalazine, can it be used? It can be used, right? And mesalamine is used in a dose of 50 to 100 milligram per kg per day. Rectal forms will be useful for distal rectal lesions. Second, we come to antibiotics. Antibiotics are the first line therapy in case of infectious complication and in perianal disease. They are also useful in mild to moderate cases of CD as an adjunct therapy. They can be combined with 5-ASAs as well. Metronidazole is usually the antibiotic of choice which is used. The dose is 10 to 22.5 mg per kg per day. Role of probiotics is not proven in pediatric CD, although there are many preparations which come where probiotics are added to it. Adults, probiotics are frequently used. Third category are the corticosteroids. They are useful for inducing acute remission, but they are not useful for maintenance purpose. Obviously, systemic steroids will never be a maintenance agent. Their side effects will come into play. So they are used in acute exacerbations. Prednisolone will be used in a dose of 1 to 2 milligram per kg body weight per day. Maximum dose of 60 milligrams should not be exceeded. They will be used for 1 to 3 weeks followed by rapid tapering. There is also a new preparation called as ileal release budesonide, special enteric coated forms which release budesonide only reaching the ileum. They are more effective than mesalamine in the treatment of active ileocolonic disease, but overall they are less effective than prednisolone. But they can be a useful thing because budesonide is relatively better tolerated compared to prednisolone when it comes to steroid side effects. Fourth category are immunomodulators. They are used as steroid sparing agents in patients who are steroid dependent, but the problem with them is they are relatively slow acting. So the agents which are commonly used, they include azathioprine and 6-mercaptopurine. These are the doses which are mentioned. They are effective in children who have a poor response to steroid or are steroid dependent. As I just told you, they take 3 to 4 months to act. So they will not be effective in acute period, but they are effective in perianal disease. Side effects of these two agents include increased risk of hepatitis, pancreatitis, skin cancers, infections and lymphomas. These days, methotrexate is also effective in acute patients because methotrexate is found to be relatively faster acting as compared to azathioprine or 6-mercaptopurine. Side effects relate to hepatic toxicity. And when you are giving methotrexate, you need to give folic acid derivatives, folic acid analogues also to the patient. Then we come to biological agents, which are one of the most costliest but most potent agents in moderate to severe disease or refractory disease. So biological agent of choice in children is infliximab. Infliximab is a monoclonal antibody which is directed against tumor necrosis factor alpha. It is also labeled as anti-TNF alpha monoclonal antibody. Infliximab is effective for the induction as well as maintenance of remission as well as mucosal healing in chronically active moderate to severe CD. It promotes healing of the perianal fistulas. It has steroid sparing action and it is even given post-operatively to prevent recurrence of the disease. It is rapidly active, given as 3 infusions on 0, that is day time at which the first infusion is given, then 2 weeks later and then 6 weeks later after the first infusion. Then after that for maintenance it is given 8 weekly. The side effects of infliximab include the same ones which are associated with anti-TNF alpha therapy. They include reactivation of tuberculosis, lymphomas in the patient, infections can develop, autoantibodies and infusion reactions have also been known to occur. Other agents which have sometimes been used, they include adalimumab, which is again an anti-TNF alpha agent. Adalimumab need not be given intravenously. You can give it as subcutaneous injection also. We have vedolizumab, which has recently been approved for use in children. It is anti-integrin alpha 4 beta 7. It is relatively slow acting, but the regime is similar to that of infliximab. So 0 to 6 week regime followed by 8 weekly for maintenance is the regime we follow in vedolizumab as well. The mechanism of action of vedolizumab is different, please remember this. Then is ustekinumab, which is sometimes used, not very frequently used, more frequently used in adults. It is anti-interleukin 12 and 23. It targets the Th17 pathway. Newer agents include a oral SMAD7 antisense oligonucleotide. It is also called as ASO therapy that targets TGF beta signaling. It is currently under trials and it's not yet approved. Then there is a role of enteral nutrition therapy. Enteral nutrition therapy is rapidly acting. So what we do is we put a nasogastric tube or we perform a gastrostomy and through that we give feeding to the child. that has been shown to be very effective in Crohn's disease patient. It is not found to be effective in ulcerative colitis, but it has equally efficacious role as steroids. In mucosal healing, it is even better. So, it is effective in acute CD as well as adjunctive therapy, superior to steroids for healing mucosa, as I just told you. It is given as a nasogastric or gastrostomy infusion, usually overnight. And disadvantages, because you are giving all the formula, all the requirements from this, the child is not able to eat orally. And there is a novel approach which is coming where 80 to 90% of caloric needs are given through the tube feeding. Remaining 10% the child has to get through the feeding. So various types of regimes are being developed, but these enteral nutritional therapies require hospitalization and expert care, expert nutritional care in experienced centers. Third is your role of surgery. There is a very limited role of surgery in Crohn's disease. Specific indications exist. And most of the surgical patients will require post-operative medical therapy. You need to give post-operative antibiotics or steroids or infliximab in majority of these patients. Surgery shows a very high recurrence risk even after bowel resection. Risk is as high as more than 50% by 5 years after surgery. What are the complications of surgery? They include fistula formation, strictures, anastomotic leaks, and short bowel syndrome. Indications of surgery in CD, they include localized disease of small bowel or colon which is unresponsive to medical therapy. You have tried all medical agents, not effective, do surgery. Second, perforation. Perforation due to any reason will always require surgery. Third, fibrous stricture with symptomatic partial small bowel obstruction. If there is a stricture where fibrosis has happened, then surgery needs to be done. In general, these days, Nelson says that in strictures, stricturoplasty, where you give an incision and then suture it transversely, is considered better in CD patients than bowel resection. Bowel resection should be avoided as much as possible in patients of Crohn's disease. Then surgery will be needed in intractable bleeding. It will be needed where abscess is there. We discussed 4 types of abscesses. You try to do ultrasound or CT drainage. If that fails, then obviously surgery needs to be done. And finally, perianal abscesses or anorectal abscesses will also require drainage. Now, how you are going to manage perianal fistula, which is frequently seen in Crohn's disease? According to Nelson, they are managed by a combined medical plus surgical approach. You place a satin through the fistula to keep the tract open while you are giving medical agents including antibiotics. If the fistula tract closes while giving medical therapy, what can happen is abscesses can develop, and then once the medical therapy has been done, then you will do fistulotomy in the patient. But fistulotomy should be done only if the sphincter function can remain active. If it is involving the sphincter, then you have very limited option and you need to consider alternative therapies. So what are the extra edge points in CD before we move towards ulcerative colitis? Fecal diversion can be useful in severe refractory perianal CD. So where, I just gave you the example. Fistulotomy is not possible. Everything else has failed because sphincter is getting involved. In these patients, fecal diversion can be done. But fecal diversion is a temporary thing. Once the fecal diversion if you have done colostomy and you are diverting fecal material away, 6 months later you try to put it back, again CD will recur. That is the problem. The risk of colon cancer is there in patients with colonic involvement. So long-standing Crohn colitis approaches that of ulcerative colitis, and so screening yearly or bi-yearly needs to be done after 8 to 10 years of colonic disease being found. And a new index has been proposed for Crohn's disease. Details will not be asked to you in the exam, but Lemann's index is the name, which is a new index for measuring the Crohn's disease in patients. Secondly, we come to ulcerative colitis. Ulcerative colitis, various types have been proposed according to anatomical involvement. The first variety is pancolitis, where the entire colon is involved. Second is left-sided colitis, where only up to splenic flexure the colon is implicated. And third is distal colitis, which is also called as proctitis or proctosigmoiditis. Now, what are the peculiar features in pediatric ulcerative colitis? The peculiar features in pediatric ulcerative colitis include, in case of children, you find that pancolitis is seen in 50 to 80% cases, more extensive anatomical involvement, right? In case of adults, it is the proctocolitis which is more common. In children, pancolitis is more common, so obviously the disease will be more severe. Proctitis, if it happens, it has less extraintestinal features, but it is also less responsive to therapy in children. What are the clinical features of ulcerative colitis that you find? As I said, diarrhea is the predominant presentation. So, blood, mucus and pus in the stool as well as diarrhea is the typical presentation. Some patients with proctitis alone, they may have constipation. Rectal symptoms are common. The rectal symptoms will include tenesmus, that is sense of incomplete evacuation, urgency of the stool, etc. Then systemic features are overall less common, although less appetite and generalized malaise has been reported in most of these children as well. There is a term called as fulminant colitis that you need to know. Fulminant colitis is ulcerative colitis where there is fever, severe anemia, hypoalbuminemia, raised WBC count and more than 5 bloody stools per day for 5 days. That is called as fulminant colitis. It is a life-threatening thing in which toxic megacolon, that is large and massive enlargement of the colon, can develop, and perforation has also been known to occur. Many patients with ulcerative colitis, especially children, they develop a chronic disease with a relapsing remitting course. Approximately 5% will have a prolonged remission lasting more than 3 years. In the remaining, it will be a relapsing remitting course. And exacerbations are commonly caused by the use of non-steroidal anti-inflammatory drugs. Extraintestinal manifestations are less common as compared to Crohn's disease. Now, there is a Montreal classification of ulcerative colitis which has been given. It talks about two aspects, extent and severity. Since it has been discussed in Nelson, so we need to talk about it. So, first of all, extent wise, there are 3 categories of ulcerative colitis which are defined. First is E1, E2 and E3. E1 refers to ulcerative proctitis where it is limited to the rectum. Second is left-sided ulcerative colitis, also called as distal ulcerative colitis, which is distal to the splenic flexure. And third is pancolitis, also called as extensive ulcerative colitis, which extends proximal to the splenic flexure. Virtually entire colon is involved. The second part is the severity. Severity wise, we have S0, 1, 2 and 3. 0 will be clinical remission, no symptoms are there. S1 will be mild ulcerative colitis, where there are 4 or less stools passed per day, no systemic illness and normal ESR is found. S1 will be moderate ulcerative colitis, where there are more than 4 stools per day but no systemic feature. And S3 will be severe ulcerative colitis, where there are more than 5 bloody stools per day, there is tachycardia, there is high temperature, that is fever, HB is less than 10.5 or ESR is more than 30 millimeters per hour. So, these are the categories of severity of ulcerative colitis. So, Montreal classification is important. In some of the books, when you try to Google, you will also find Vienna classification, but Vienna classification for CD and ulcerative colitis are not validated for use in children. So, we will not talk about them. Now, what is the risk of colon cancer? Colon cancer is a reality in ulcerative colitis and major cause of long-term morbidity and mortality. The risk of colon cancer begins to increase after 8 to 10 years of diagnosis with the disease. The risk is almost 0.5 to 1% per year starting from 8 to 10 years of age. So, proctitis alone, if it is present, almost no risk is there. Pancolitis will have the maximum risk. So, many cases of colon cancer, they are preceded by dysplasia, and so if you pick up dysplasia on colonoscopy, you can actually do limited resection and prevent that part from developing colon cancer. So, what we do is we advise colonoscopy every 1 to 2 yearly starting from 8 to 10 years of age. And when you do colonoscopy, you will take biopsy, look for dysplastic lesions. Now, how you are going to make the diagnosis of ulcerative colitis? Blood investigations are less dramatic, although anemia can sometimes be seen. Fecal calprotectin will be elevated here as well. So, fecal calprotectin in CD also, in ulcerative colitis also. Barium enema, when you do, in barium enema, you will find features of whether there is localized involvement or the entire colon is getting involved. So, look at this picture, you will find that there is dilatation with diffuse ulcerative lesions being present in the entire colon. So, this is pancolitis seen on barium enema study. Flexible sigmoidoscopy and colonoscopy followed by biopsy are considered to be the investigation of choice for ulcerative colitis. You will avoid colonoscopy in fulminant colitis because there is a risk of perforation in these patients. What are the biopsy findings that you will do? You will find that there is cryptitis, crypt abscess, separation of crypt by inflammatory cells, foci of acute inflammatory cells, edema, mucus depletion and branching of crypts. Branching of crypts is a particularly useful sign Branching of crypts is never seen in infectious mimics of ulcerative colitis. Now we come to a specific rare but life-threatening complication called as toxic megacolon. Toxic megacolon is said to be there. It is seen in patients of fulminant colitis. The name itself is saying there are features of toxicity, systemic toxicity, plus megacolon on radiological examination. On doing a X-ray, plain X-ray, you will find a dilated colon with the transverse diameter being more than 6 centimeters. Toxic megacolon has a high risk of rupture. So signs of systemic toxicity like fever, shock, etc. will be there. There is a high risk of rupture. Toxic megacolon is a frequent complication which requires close observation. Many cases you will need to do surgery also in these patients. So this is a X-ray finding which is showing a massively dilated colon. This is a toxic megacolon picture. Now there is a activity index which is given. We call it as pediatric ulcerative colitis activity index. There are 6 items included in this ulcerative colitis index. These items are marked, they are graded, and various types of scores are obtained which tell you how severe the ulcerative colitis is. So this is the table. So there are the 6 markers include abdominal pain, rectal bleeding, stool consistency of most stools, number of stools passed per 24 hours, whether there are any nocturnal stools causing awakening, and activity level of the patient. Higher the score, there are particular parameters given for each score. You need not go into the details, but at least give a reading. At least you should remember the names of the headings and broadly know what are the components included in each. Higher the score, more severe the ulcerative colitis is. Right? Coming to the management of ulcerative colitis. 5-aminosalicylates continue to be the initial first-line therapy here also. If they are useful in mild to moderate ulcerative colitis, mesalamine can be used or balsalazide can also be used, and they are useful to reduce active inflammation and recurrences. Important thing, they have also been shown to slightly reduce the risk of colon cancer as well. That is important. 5% patients have an allergic reaction to 5-ASAs. So allergic reaction is one of the most common side effect. Enema and suppository forms will be useful in patients with proctitis. Second, we have other therapies which include steroids. They can be useful in moderate to severe cases as well as unresponsive patients. They are useful for acute flare but not for maintenance, just like for CD. Extended release budesonide is here also. It can be used in mild to moderate ulcerative colitis. Then we have steroid sparing agents like azathioprine and 6-mercaptopurine. Infliximab will be useful in severe, acute as well as chronic cases in moderate to severe cases. So other than infliximab, adalimumab has also been used. Methotrexate is not mentioned in ulcerative colitis use in case of Nelson. And tofacitinib, which is a JAK kinase inhibitor, it is a JK inhibitor which is sometimes used in adults, and vedolizumab is again approved for use in adults. These two biological agents are not yet approved in children. Antibiotics can be given with or without probiotics, but they have a limited role in the management of ulcerative colitis. Now, surgery plays a much important role in ulcerative colitis compared to Crohn's disease. So, colectomy will be done for intractable disease in case of any complication or fulminant disease which is unresponsive to medical management. The best approach is you combine colectomy with an endorectal pull-through procedure which allows the child to remain continence, in this procedure the distal part sleeve of rectum is left and we go from the inside. Endoluminal approach is taken and pull-through procedure is performed. A temporary ileostomy will be needed in some of these patients. These surgeries, they have a particular problem called as pouchitis. This is seen in almost 30 to 40% of patients. Pouchitis, if it develops, can be managed with either antibiotics or probiotics. The antibiotics useful include oral metronidazole or ciprofloxacin. Probiotics have also been shown to reduce the occurrence as well as chances of proctitis in these patients. So this is all about the management of ulcerative colitis. In general, to summarize, ulcerative colitis and Crohn's disease, they both are very frequent in case of children and their incidence worldwide is rising, particularly in an Indian setting. There are relative differences between the two, which one is getting involved where and what is the therapy are the areas where you should be focusing. So for super specialty exam, the etiopathogenesis of inflammatory bowel disease, their relative differences, as well as their management approach for each inflammatory bowel disease. In IBD, these are the areas which require focus when you are preparing for super specialty exam. Thank you very much.